Hello, my name is Shayna Butler. I'm a graduate student in Cayuga's Master of Social Work program. My research proposal asks a question that feels kind of personal to my field placement. When the question is when someone is in a mental health crisis, specifically when they're experiencing suicidal thoughts, does it matter where we respond to them? Does meeting them at their home or in their community lead to a better outcome and bringing them into the emergency room? That's the heart of what I was investigating in this paper. So I want to talk a little bit about the paper and kind of go through all the pieces of it. So the point at the beginning underneath the gold bar is my primary research question is among adults presenting with suicidal ideation, how does mobile crisis intervention using the Columbia Suicide Severity Rating Scale or the CSSRS and safety planning intervention compare to emergency department or psychiatric evaluation in reducing hospitalization rates and improving short-term stabilization outcomes? So I developed this question directly from my field placement at Clifton Springs CPEP, the Comprehensive Psychiatric Emergency Program there. It's located within the Finger Lakes region, and I've spent both of my field placement time periods in that. So every shift, I see how differently patients respond depending on whether they're met in their own space or by a mobile crisis team, because we have both, versus arriving at or being brought into the emergency room, whether it's on their own accord or through police or emergency services. And I wanted to study that difference systematically. So there's statistics on this panel to the left column, and the statistics in this poster tell a very compelling story. The CDC reports that over 48,000 suicide deaths annually, that there's 48,000 suicide deaths annually in the United States. And that's the SAMHSA data, and it shows that mobile crisis teams can divert up to 87% of crisis callers away from the emergency department. And that mobile response costs roughly about 60% less than a traditional ER visit. And in the grand scheme of things, that's huge. Those numbers are huge. Despite this, only about 700 mobile crisis programs currently exist nationwide, which that number sounds profound, but if you think nationwide, it truly is not. So right here in New York State, the expansion of the 988 or the 211 crisis lines and the Community Health, Mental Health Reinvestment Act are actively rebuilding how crisis care is delivered. The Finger Lakes region is a part of that change, and I believe we actually have the opportunity to generate local evidence that supports and to help guide it. So if we're scrolling up in my poster a little bit more, you can see on the structure of this research, I use PICO framework, which is standard and evidence-based health research. So that stands for the population. So my population was adults 18 or older presenting with suicidal ideation who score a 1 or higher on the CSSR, meaning they have active ideation. They're not just passive thoughts about death. My intervention is my mobile crisis team deployment and using that CSSR for structured risk screening and safety planning as the primary intervention tool. My C is my comparison, which is traditional emergency department psychiatric evaluation and using safety plans at discharge. And then my outcome, does it reduce hospitalization rates and short-term care crisis stabilization and a 30-day engagement period with community behavioral health resources? This type of framework keeps my research really focused and ensures that every component of my design connects back to my answerable and measurable question that's on the gold bar. So My hypothesis box. So that's directly under my PICOs, my PICO. So my hypothesis in the beginning was that mobile crisis interventions would produce lower hospitalization rates, better short-term stabilization, and higher community follow-up compliance compared to emergency departments evaluation. And the reasoning behind this hypothesis is rooted in the theory that I'm going to walk through right now. So we're going to kind of go back up to under theoretical framework. This is crucial in my moving forward, and grounded in this study are three complementary theoretical frameworks that I really operated on different levels of social work practice. So my first one was crisis intervention theory. So I drew from Kaplan and Roberts' 7-stage crisis intervention model that gives me actually that micro level lens. It tells me that individuals in acute crisis are uniquely open to intervention. Roberts states and maps actually directly onto my research design and states that the CSSR aligns with the early assessment stages and safety planning concepts to stages 5 and 6, exploring alternatives and developing an action plan. The second theoretical framework I used was the ecological systems theory. I researched using Bronfenbrenner, and this is central to my hypothesis in that it states when a mobile crisis team meets someone in their own home or community, they're working within that person's microsystem, their familiar environment, their natural supports, etc. So emergency department visits actually pull people out of that environment, which Bronfenbrenner's theory predicts would really undermine recovery and reduce engagement with follow-up services that can be crucial to their success and actually perpetuate recidivism. My third is cognitive behavioral theory, specifically Beck's CBT framework and Stanley and Brown's safety planning intervention. So the safety planning intervention strategy engages social supports and addresses means restriction. It really was designed to be used in like both inpatient and outpatient settings, which is why it makes it ideal as a consistent intervention across both study groups. Stanley's landmark in 2018 study in JAMA Psychiatry showed that safety planning initiatives specifically reduce suicidal ideation in emergency department settings. And my study asked whether these results are even stronger in a mobile community-based context. So that's kind of why I worked through these different theoretical frameworks. So moving on from that, we're going to scroll down a little bit to methodology. My methodology, this study uses a quantitative quasi-experimental two-group comparison design. So I wanted to be transparent about why we can't use a random controlled trial, because we simply cannot randomly assign someone to mental health crisis, to one type of care over the other. Crisis presentations are often unpredictable, and people arrive by ambulance or by crisis call. They can come through family walk-ins, and that's truly it's the ethical reality and a clinical one. So a quasi-experimental design is established ethically appropriate standards for behavioral health in the emergency research aspect of my question. So my sampling was with 120 adults. We were going to recruit over 12 months from Clifton Springs CPEP, the Newark hospital that we contract with, our emergency department services at Clifton Springs, and our 988 and 211 referral lines, all within the Finger Lakes region, which spans a fairly large aspect of our different counties and the counties that surround us. They're split evenly, the groups, into 60-60. So Group A would be receiving mobile crisis intervention and referred to that aspect, and 60 in Group B that would be receiving a standard ED evaluation. So that 60-60 split reflects power analysis requirements, and it also builds in room for participant attrition, which is a realistic concern in crisis populations. We often see people fall off or out of things, or, re-enter systems of crisis or need. We're going to scroll down a little bit more to measurement instruments. So we have 3 validated instruments that we're using across this study for both groups. So we're using the CSSR, which is again, the Columbia Suicide Severity Rating Scale, as our anchor tool. It's clinician administered, and it covers the 5 categories of suicidal ideation, and each positive response increases risk severity. It's also endorsed by SAMHSA and the New York State Office for Mental Health, so it makes it perfect for the hospital setting. It's already currently being used at Clifton Springs. I use it in my field placement when doing assessments, which means this study doesn't require introducing new clinical tools into the workflow. It's clinical tools that are familiar with most of the organizations that we're working with through the study. The next instrument would be the Beck scale for suicidal ideation and the BSSI. That adds a self-reporting dimension to this research project, particularly for the ED group. So when paired with the CSSR, it really strengthens the internal validity through triangularization of findings across the data collection points. This gives individuals to answer for themselves and also the clinical aspect. And the third and final tool being used is the safety planning intervention. That's administered to both groups, which is actually a huge strength of this design, because the prevention initiative is present in both arms of the study. It serves as a consistent intervention baseline, meaning that any outcome differences we observe can be more confidently attributed to the setting or the modality of care, not the actual presence or absence of a specific tool. So it gives us a really good basis for our findings to answer that specific question. So we're going to do this by going kind of up a little bit. How we're collecting data. We're collecting it through a procedure that follows 8 really structured steps. So steps 1 and steps 2 are really what we are calling the setup phase, getting the IBR approval for the research study, signing our MOUs with our partnering sites, and really making sure that we're training, or they've had the training of all participating clinicians on standardized tools that were being used for the administration and the EPIC online data documentation system. Step 3 is participant identification and consent. Voluntary participation is mandatory, and it's emphasized from the start with informed consent, really that we're informing our patients, because of the setting and what we're doing, of every step along the way. Step 4 is a baseline data collection. So within 72 hours after a patient's being identified in a crisis event, we're looking at demographics, we're looking at prior hospitalization history, we're looking at their insurance status, we're looking at any co-occurring diagnoses that these patients might have, and the initial CSSR and BSSI scores all entered into the EPIC system. So we are checking their charts once, and we're checking their charts twice to really make sure that we understand this patient. Steps 5 through 7 are the interventions, right? So our interventions and follow-up phases. For Group A receives the mobile crisis protocol. Group B is the emergency room or department protocol. So both groups receive follow-up calls at 7 days prior to discharge. And then again at 30 days. Those calls are re-administered, and screening tools, and they verify the referral connections. So we're not only checking back in once, we're checking back in twice, and we're following up that with the referral connections, that they've been continuing services with what we're recommending, and that they haven't fallen off of our research study. Step 8 really is the data analysis step, and the final step, it's the reporting after the 12-month recruitment window closes. So we're looking at then in our EPIC system what the follow-ups have been. Have they been attending? Have they been doing all that they're supposed to do? And then going from there. When we do that, we'll get a better idea of, our mobile crisis versus our ED. I wanted to, though, however, touch base on my poster as well as the limitations that we do note. I noted in my papers, but I want to note as well because for any I want to acknowledge limitations. It's a marker of rigorous and ethical research. It's not a weakness. And I want to be honest about the 4 limitations that I really can see. The first one being selection bias is inherent to quasi-experimental design. Without this random assignment, these group differences may reflect pre-existing clinical or demographic factors rather than the intervention itself, right? So regression models can help control this, but they can't eliminate it entirely. So selection bias is going to be a huge limitation in this study. Another one is generalizability. It's really limited by non-probability sampling within the Finger Lakes area. The Finger Lakes has a very specific configuration of crisis services. Clifton Springs CPEP is not typical to every region. This is kind of, works through this. It's a great state-of-the-art program, and we're making tons of findings, and these findings may not transfer directly to an urban or a rural setting with different resource structures. Another one is participant attrition. It's a known risk, especially in crisis populations. Crisis populations are transient a lot of the time. The 60/60 sampling size is intentionally built to absorb that expected dropout while preserving, a numerical statistical power that we might have in the research. And then the final one is single healthcare system data. It means that all documentation really flows through Epic within the Rochester Regional System, which creates consistency, but it also limits cross-system replicability. So it is part of the limitations, and I would be remiss to not mention it. So if we keep going down, I want to talk about why this is significant. So what is the point to the implications panel? The implications of this research operate in all 3 levels of social work practice, to be honest with you. So at the macro level, the findings directly inform how individual clinicians assess suicide risk and select intervention modalities. If mobile crisis produces equivalent or superior outcomes, clinicians can then approach those settings with greater confidence. Mobile crisis can then grow and expand. And with data to back reduced reliance on emergency hospitalization, we can start looking also at cost efficiency. At the macro level, this evidence can reshape referral pathways between mobile teams, outpatient behavioral health providers, and hospital systems. That directly aligns with the NASW competencies 7, 8, and 9. So really the assessment, the intervention, and the evaluation phases that we really need to follow as social workers. And finally, at the macro level, this study contributes to an active conversation in New York State about mental health crisis infrastructure, right? The Community Mental Health Reinvestment Act calls for ongoing expansion of community-based care. And research like this is grounded in specific region using validated tools and following ethical guidelines, which provides the kind of localized evidence that policymakers need to see. So really in closing, this research kind of asks whether the where and how we respond to crisis changes how well we respond. My hypothesis is that meeting people in their communities through mobile crisis teams using these validated tools like the CSSR and the safety planning will produce better outcomes than the default of emergency room evaluation. The design is ethical, it's grounded in 3 complementary theories, and it uses validated tools that are current. It's also anchored in real-world crisis landscape of the Finger Lakes. I believe this work has the potential to strengthen community mental health within our region. I'm proud to connect that to my field placement practicum at CPEP, and I'm really happy that I was able to present about it. Across the bottom of my poster, I put some links to different suicide and crisis prevention programs or resources. And I would just hope that anyone who might be in need of them would be able to use the link provided. Thank you for taking the time and listening to my presentation. I'm going to stop sharing right now. And I appreciate your time.